Well, hello and welcome. In this seminar series, I'm talking about the diagnosis of the pathology in the family courts. And in this particular segment, I'm going to be discussing the diagnosis of a persecutory thought disorder, a persecutory delusion. So, to begin with, just to describe what a persecutory delusion is, a delusion is a fixed and false belief that's maintained despite contrary evidence. So there's several parts of that. It's a false belief and it's maintained despite contrary evidence. And we'll be presenting the contrary evidence during the assessment to see how the person processes that information. The delusion is considered within a category called a thought disorder. And there's various types of thought disorder. This is a particular type. It's a delusion. It's a failure in linear and logical reasoning system of the brain. That's the frontal lobe executive function systems. So basically what we're going to do is a sweep of the linear and logical reasoning system of the frontal lobe to pop the delusion out right in the session there. And in this case, it's going to be an encapsulated delusion. And that means it's a limited scope delusion. So it's not interfering with a lot of the person's life, and it's not a broad kind of false belief, but it's very limited to a particular situation. And so to diagnose a delusion, the first thing that's necessary is it must be a false belief. So that's going to be the first aspect of determining whether or not we have a delusional disorder. The second part is that it's maintained despite contrary evidence. So we're going to look at the degree of conviction in that belief. If there's doubt or if the person firmly believes it, then we'll present some contrary evidence and see how the person processes that contrary information. So a delusion is a type of disorder. It's a problem with linear and logical reasoning. And for the normal people who process information normally or within a normal scope, we tend to follow the evidence to reach our conclusions. But a delusion starts the other way around. It starts with the conclusion as fixed, and then it constructs the evidence to match the fixed beliefs. And so that's a critical element in the assessment. You're looking at whether or not the person is following a set of evidence to reach their conclusion, or is their conclusion already fixed? And so you're looking not at what the content is. You kind of look at that too, bizarre delusions, that sort of thing. But what we're actually looking at is how the person reaches their conclusion. Is there a linear and logical approach to it? Or is a conclusion fixed and then they're constructing evidence up here? And then when we present the contrary evidence, we'll want to see them sort of processing that evidence to reach their conclusion. A diagnosis of delusion looks at how they arrive at their beliefs, not the content of those beliefs. So people have differing views and beliefs, and so the issue for a thought disorder is how the person arrives at those beliefs. The pathology in the family courts is a psychological collapse of a narcissistic or borderline parent from unresolved trauma into an encapsulated persecutory delusion about the other spouse and parent that's triggered by the inherent rejection of the divorce. So this is not a psychotic range delusion like you might find in schizophrenia or even in bipolar disorder with psychotic features. This is a trauma origin thinking disorder, thought disorder. And what happens is the person, as a child or young person, has such significant trauma in their world that it distorts their thinking and perception about situations. And then when they enter the rest of the world, they see the world through this lens of their unresolved trauma that sees dangers where none exist. So it's a trauma origin delusion rather than a psychotic delusion that we might have off of schizophrenia. And here's from Theodore Milan, who's grand high kahuna of thought of personality disorders, regarding how the narcissistic personality will collapse into persecutory delusions. We know this. So Milan says that under conditions of unrelieved adversity and failure, narcissists may decompensate into paranoid disorders. Owing to their excessive use of fantasy mechanisms, they are disposed to misinterpret events and construct delusional beliefs. See, we know they fall into delusions under stress. Divorce is stress. Unwilling to accept constraints on their independence and unable to accept the viewpoints of others, narcissists may isolate themselves from the corrective effects of shared thinking. Alone, they may ruminate and weave their beliefs into a network of fanciful and totally invalid suspicions. Among narcissists, delusions often take form after a serious challenge or setback has upset their image of superiority and omnipotence. That's the divorce. They tend to exhibit compensatory grandiosity and jealousy delusions, in which they reconstruct reality to match the image they are unable or unwilling to give up. Delusional systems may also develop as a result of having felt betrayed or humiliated. Again, that's the divorce. That's what's going to trigger on divorce. Here we may see the rapid unfolding of persecutory delusions and an arrogant grandiosity characterized by verbal attacks and bombast. And so the divorce induces a narcissistic injury in them, that they are now the rejected parent. And so they fall into a delusional thought disorder, persecutory delusions, to recorrect the situation in their own mind. I'm not the rejected one, you are. I'm not the inadequate one, you are. And they create the shared delusion with the child to put the targeted parent in that role of the rejected one, the inadequate parent or spouse. In this situation. So we know that narcissists will collapse into delusional disorders under stress and under divorce. And so that's exactly what's happening in the family courts because of the narcissistic injury. Now, as for the borderlines, the term borderline actually comes from on the borderline between neurotic and psychotic. So we know the borderline personality will easily collapse into a persecutory delusion. And here's from Barno. He did a meta review of psychosis in the borderline personality. And he says, this review reveals that psychotic symptoms in borderline personality disorder patients may not predict the development of a psychotic disorder, but are often permanent and severe and need careful consideration by clinicians. Therefore, adequate diagnosis and treatment of psychotic symptoms in borderline personality disorder patients is emphasized. So we know that, and we know there's a certain percentage of people with borderline personality, and they're going to wind up in the courts. So we should anticipate we're going to be seeing these delusions. And in conclusion, we therefore suggest that it's not a cognitive developmental deficit, but rather a tendency to construe interpersonal relations as malevolent. Note that word, malevolent, that characterizes borderline personality disorder. And this may be shared with certain psychotic disorders. Well, what's certain psychotic disorders? A persecutory delusion. Here's the definition of a persecutory delusion from the American Psychiatric Association. Persecutory type: delusions that the person or someone to whom the person is close, i.e. the child, is being malevolently treated in some way. Okay, you Google malevolent, it's having or showing a wish to do evil. And so the borderline personality collapses into a persecutory belief that they are being malevolently treated in some way, and they'll often make allegations of abuse, the other person's being abusive to them, because they feel that they're being constrained within their emotions and it's painful and they don't like that, and the other person's being malevolent or treating them in a malevolent way, which is the persecutory delusion off of that. And so one of the features as we're doing the assessment of the pathological parent, or the child who has a shared delusion, is we'll want to look at whether or not they believe that the targeted parent has a wish to do evil to them. Okay, and is that a false belief, or does the targeted parent have a wish to do evil? We'll talk about that in a second. But we're going to be looking at that component. Does the parent believe that the child is being malevolently treated in some way by the targeted parent, and that does the child share that belief system? So, for the family court pathology, for the persecutory delusion, we're going to be looking at the allied parent. And so, does the allied parent have a fixed and false belief, a delusion, that the child, someone to whom the parent is close, is being malevolently treated in some way by the targeted parent? And then for the shared delusion, it's does the child also have a fixed and false belief, the delusion, that the child is being malevolently treated in some way by the targeted parent? So here's a description of a shared delusional disorder, shared psychotic disorder from the American Psychiatric Association. The essential features of a shared psychotic disorder, a folie à deux, is a delusion that develops in an individual who is involved in a close relationship with another person, sometimes termed the inducer or the primary case, who already has a psychotic disorder with prominent delusions. So what we would be having in the family courts is the allied parent has a persecutory delusional disorder persecutory type, and they're in a close relationship with the child. And the primary case is the allied parent, and they are the inducer of the persecutory delusional beliefs in the child. And so in the family court pathology, the child is involved in a close relationship with the allied parent, the inducer, who has a persecutory delusion. So the American Psychiatric Association goes on in its description of a shared delusional disorder. Usually the primary case in the shared psychotic disorder is dominant in the relationship and gradually imposes a delusional system on the more passive and initially healthy second person. So that classically fits the family courts. The parent is dominant and the child is in a more submissive, dependent role. And the induction of the delusional beliefs tends to be gradual. So it happens pretty much after the divorce takes place, and then the child gradually comes to believe that the targeted parent is malevolently treating them some way, and then it goes down the siblings. So it starts with the eldest child typically, and then the other children are recruited into this false belief. So individuals, excuse me, individuals who come to share delusional beliefs are often related by blood or marriage and have lived together for a long time, sometimes in relative isolation. So there you have the parent and child are related by blood. And if the relationship with the primary case is interrupted, the delusional beliefs of the other individual usually diminish or disappear. And so that's important to note that the treatment, according to the American Psychiatric Association, is to separate the secondary case, the child, from the primary case of the parent here. And that would be consistent with the psychological abuse diagnosis as well. We protect the child from child abuse. And so if a parent is producing a delusional belief in the child that then destroys the child's attachment bond to the other parent, that's child psychological abuse. So we would want a protective separation to protect the child. But also, that's the treatment for a shared delusion, is to separate the child from the primary case. As long as we're sending the child home to this delusional parent, that parent's going to keep inducing the delusion in the child. And so we're constantly battling, and we're going to wind up ripping the child apart between our efforts to restore normal and healthy development and the pathological parent's desires to keep the child delusional and pathological. So that's important to notice there, that final statement, that if the relationship with the primary case is interrupted, the delusional beliefs of the other individual usually diminish or disappear. So that's the treatment for shared delusion. That's why it's so important to get a diagnosis. Diagnosis guides treatment. Once we have the diagnosis of a shared delusional disorder, that then guides our treatment for separating the child from a delusion. If we don't have the diagnosis, we don't have the treatment-related guidance that the diagnosis provides. So, continuing from the American Psychiatric Association, although most commonly seen in relationships of only two people, a shared psychotic disorder can occur in larger numbers of individuals, especially in family situations in which the parent is the primary case and the children, sometimes to varying degrees, adopt the parent's delusional beliefs. And so you can see it's especially in family situations, and that's what we have in the family courts. And so this shared delusional disorder is spot on what's going on in the family courts, and it needs to get properly assessed and accurately diagnosed so that we can take the proper treatment steps for the child abuse and for the delusional disorder that's being induced in the child. And then you'll notice that the children will adopt the delusional beliefs to varying degrees. And we'll see this in the family courts when we have multiple children. We'll see the eldest child who has the strongest persecutory delusion. The targeted parent is malevolently treating that child in some way. And then as you go down the siblings, it becomes less and less. Although over time, they all kind of join in this shared delusion because of the splitting dynamic and that's of the narcissistic borderline dark personality, where things are either one way or the other. So once you get the oldest child will begin to put pressure on the younger children, and they will all move over to that side of the family conflict. So, but again, you have an exact description of the pathology in the family courts by the American Psychiatric Association. This is the pathology right there. There it is. And it needs to be diagnosed. It needs to be assessed and diagnosed in the family courts. Creating a delusional disorder, a psychotic disorder in the child that then destroys the child's attachment bond to the other parent is child psychological abuse. Duty to protect obligations are active. And in all of these cases, these high conflict cases where your child's rejecting a parent, we need to get a proper risk assessment for the possible child abuse and the possible shared persecutory delusion that's going on. Continuing from the American Psychiatric Association, aside from the delusional beliefs, behavior is not otherwise odd or unusual in shared psychotic disorder. Impairment is often less severe in the individual with a shared psychotic disorder than in the primary case. So again, that totally matches up with what we have in the family courts. The child's not delusional at school, they're not odd, they're not acting unusual, except in this one little area relative to the targeted parent. Then you'll see the full display of the delusion, but otherwise they're not. So it's not like a schizophrenia where the person's, screaming on street corners or something. This is a trauma origin thought disorder. And so it's going to be encapsulated. It's going to be directly focused towards the targeted parent and potentially towards the family of the targeted parent, that they're being malevolently treated in some way by their grandmother or by their uncle or somebody. And so that it's the child does not display a broad array of psychotic symptoms. It's very focused. And then the child's symptoms will tend to be less so than the parent. So on the assessment, when we're doing the assessment, I typically recommend meeting first with the allied parent to hear all the concerns of that parent, because the differential is possible child abuse towards the targeted parent. So I want to hear if there's targeted abuse, but I also want to do the mental status exam of running down and seeing why they believe the child is being malevolently treated in some way by that parent. Is there evidence to support that, or is it constructed evidence? But I will also tend to see a stronger belief in that malevolent treatment in the parent than I will in the child. Not always. The parent will sometimes, a allied parent will sometimes display as unknowing. I don't know why the child's rejecting the other parent, because they're trying to manipulate everything and appear that I'm not inducing this. I have no idea. And that's when that happens, I will challenge the parent and say, wait a minute, you have a possible child abuse here. Your child's trying to get away from the other parent, and you have no idea, no curiosity as to why the child's doing this. That doesn't make sense to me. So, and then here's from the American Psychiatric Association about the course, the expected course of a shared delusional disorder. Without intervention, the course is usually chronic because this disorder most commonly occurs in relationships that are long-standing and resistant to change. With separation from the primary case, the individual's delusional beliefs disappear, sometimes quickly and sometimes quite slowly. So again, notice they tell us again, with separation from the primary case, the individual's delusional beliefs disappear. So twice, the American Psychiatric Association is giving us treatment-related guidance on what to do for this. We separate the child from the primary case. And if we don't get treatment for this, it's going to get worse. It doesn't spontaneously improve. And if we're treating, something else, if we don't diagnose the delusional disorder, it's going to get worse. And let me say this about treatment and treatment failure. There's only two causes of treatment failure. And either A, you've misdiagnosed the pathology and we're treating cancer with insulin, or B, the diagnosis is accurate, but the treatment for that diagnosis is being incompetently delivered. Because if your diagnosis is accurate and your treatment for that diagnosis is competently delivered, the pathology will be resolved. And so it's only one or the other of those two things, maybe both, but it's one or the other of those causes. And so typically we will look at diagnosis first. And so if we're not getting treatment response within 6 weeks, 3 months, definitely by 6 months, but I would begin to think about it. I want to see treatment gains at least 6 weeks. And if we're not seeing treatment gains, then we're going to reevaluate our diagnosis. Did we get an accurate diagnosis off of this? Because if we treat cancer with insulin, the patient's going to die from the misdiagnosed cancer. So we need to get an accurate diagnosis. And when child abuse is a considered diagnosis, our diagnosis has to be accurate 100% of the time, because misdiagnosing child abuse is too devastating to the child. So we have to do what we have to do to make sure we return an accurate diagnosis in these families. And here's the differential diagnosis for that. So the differential diagnosis is first, a child rejecting a parent, child seeking to flee a parent, a directional change in the child's attachment bonding motivations. That the only thing that causes that is child abuse by one parent or the other. Let me talk about that for a second. That the attachment system is the brain system for love and bonding, okay, and also manages grief and loss throughout the lifespan. And as a motivational system, a primary motivational system for love and bonding, the attachment system has a direction. All motivational systems have direction. Eating, sex, pain, pleasure, attachment, they all motivate towards a direction. That's what makes them a motivational system and not a regulatory system that goes up or down. These are motivational systems, because the other motivational system direction for attachment is death by starvation and predation. And so over all the millions of years of evolution, a very strong motivational system developed in children to bond to the parent, because the other motivational direction is death. So that gets eliminated. So that's the origins of an attachment bond, an attachment motivation. Now, if you have a child who is seeking to flee a parent, the only cause of that is abusive range parenting by that parent, because otherwise that child's going to want to bond into that parent. But the child seeking to flee that parent, that's child abuse by that parent. Or It's a false attachment pathology, a factitious disorder imposed on another. And we'll talk about that diagnosis later. But and so it's either an authentic attachment pathology by the targeted parent, or it's a false factitious attachment pathology. However, and that's going to be child psychological abuse by the allied parent. So either way, though, based on just the child's symptoms of seeking to flee a parent and get away, just based on those symptoms, the diagnosis is going to be child abuse. We just don't know which parent yet is abusing the child. So in all of these cases, all of these family court involved cases, we need to get a proper risk assessment for child abuse to determine which parent is abusing the child, because I know one or the other is because of the child's symptoms. So we need to identify which parent is abusing the child and get the court accurate information about that so we can take the protective steps necessary relative to the targeted parent or the allied parent, whoever's doing it. So for the differential diagnosis for the targeted parent, we have possible physical abuse, possible sexual abuse, possible neglect, and possible psychological child abuse. So those all are possibilities for the child's symptoms. The other set of possibilities for the allied parent is a delusional disorder, shared persecutory type. That's how it would be written in the diagnostic section of the patient's medical record. That's a DSM-5 diagnosis of 297.1. Then it's also a factitious disorder imposed on another, a false attachment pathology being imposed on the child for secondary gain to the allied parent. And I'll talk about that in a separate seminar, how to diagnose a factitious disorder. But either one or both of those is going to be psychological child abuse as well, DSM-5 995.51. And we're concerned in this about spouse or partner abuse of the targeted parent by the allied parent using the child as a weapon. So let me talk about that for a second, because we have two possible dangerous pathologies here. Three, actually. We have the possible child abuse by the targeted parent, but we have possible child psychological abuse by the allied parent and possible spousal abuse of the targeted parent by the allied parent using the child as a spousal abuse weapon. Now, there's three types of dangerous pathology: suicide, homicide, and abuse. Child abuse, spousal abuse, and elder abuse. That's a category of pathology called dangerousness. So there's three types of dangerous pathology. Whenever a mental health professional encounters a dangerous pathology, duty to protect obligations become active, and then we have to do three things. First, we have to conduct a proper risk assessment for the danger involved. So that might be a suicide assessment or a spousal abuse assessment, whatever it is, we have to personally conduct the risk assessment or ensure that one gets conducted. So if I'm not available or can't do the risk assessment for suicide, I might get the patient to an ER for the assessment by the ER for the suicide. Or if it's child abuse, I would refer the child over to Child Protective Services and notify them to conduct the proper risk assessment for the child abuse. But we have obligations, duty to protect obligations. So first we have to either conduct a proper risk assessment or ensure that one gets conducted. Second, we have to take an affirmative protective action to make sure everybody's safe. So for suicide, that might be increasing the frequency of sessions or arranging for telephone calls to check in, or activating the social support or family support around the person if we have proper permissions and things. So we have to take some sort of protective action. The third thing we have to do is document in the patient's medical record, in their chart, the results of the risk assessment, if we conducted it, and the protective action we took, such as a referral to the ER or CPS, or enlisting the family support or doing things like that. So we have to get a proper risk assessment, take a protective action, and document what we did. That's for all dangerous pathologies. And here in the family courts, with the child's symptoms of seeking to flee a parent, we have possible child abuse by the targeted parent, We have possible child abuse by the allied parent, and we have possible spousal abuse by of the targeted parent by the allied parent. So I've got three dangerous pathologies potentially involved. Duty to protect obligations are active for all involved mental health professionals, the individual therapists, the family therapists, the assessing forensic custody evaluator. I don't care who the mental health license is. With this pathology, duty to protect is active based simply on the child's symptoms. So if the individual therapist is not going to personally conduct the risk assessment for possible child abuse by the targeted parent, possible delusional disorder by the allied parent, possible spousal abuse of the targeted parent by the allied parent using the child, if the individual child therapist isn't going to assess for that, they still have an obligation to make sure that assessment gets conducted, such as writing a letter to the court saying, I'm worried about this situation. We need a larger, broader assessment on this situation because it's not my role as a child's therapist to meet with all the family. However, it is their role as part of the intake. Given that the differential diagnosis you got here, if you're not competent in assessing for a delusional thought disorder, you should not be doing individual therapy with a kid who has a delusional thought disorder. You should get consultation on it. You should get competent in it. And so the boundaries of competence, the absence of competence in the mental health people in the family courts is pretty much universal. Okay, so we're getting failure in duty to protect. We're getting them, the individual child therapists are believing the shared delusion. And if they believe the shared delusion, they become part of the shared delusion, part of the pathology. They believe the targeted parent is malevolently treating the child in some way, and therefore they respond to the child as if that's true, which means they become a participant in the child abuse by inducing the false delusional belief in the child because they believe it's true, because they're part of the shared delusion, because they're practicing beyond the boundaries of competence. So this is really, really bad what's going on in the family courts right now. We need to get this out for proper assessment. Now, the issue with a delusional disorder is we have to rule out that the targeted parent is abusing the child, because that's the first thing. If a child is seeking to flee a parent, the first thing we're going to consider is the targeted parent abusing the child in some way? And for a delusional disorder, the criteria is it's a false belief. So the first thing we will do is rule out that the targeted parent is abusing the child. And that's typically where I do in my first session with the allied parent. I will want to know, what are the abuse allegations? What are the allegations relative to the parent? I'll look at a mental status exam of them, see if those are supported by by logical kind of reasoning, or whether they're a thought disorder in the process. And if there's any concerns, to get the child out to CPS for assessment of sex abuse or assessment of physical abuse. Now, when CPS returns their finding, that's it. That's the finding. Okay. If they find yes or no, that's the finding. If they find in the middle and say maybe we don't know, then it's still an open question. But if they decide yes or no, that's it. Mental health people do not reinvestigate. They're the trained people. We don't go in and because we could do a lot of damage by our questions and by our stuff. So we get it out to a proper assessment by CPS for physical, sexual, or neglect abuse. Psychological abuse is not a mandated report because it's too complex for CPS. So that requires then, it's still a dangerous pathology. So then the mental health professional has to conduct the proper risk assessment for child psychological abuse. If that's a concern for the targeted parent, are they excessively angry and critical and mean of the child and sort of things? Or is it a persecutory delusion being created by the allied parent, the narcissistic borderline parents collapsing into delusional beliefs and creating that shared delusion in the child? Is it psychological child abuse by that parent? So we need to do that proper assessment in all these cases. But now, if we can rule out, when we rule out the persecutory or the authentic child abuse by the targeted parent. Now we move over into the assessing the delusional thought disorder. And the assessment for a delusional thought disorder is called a mental status exam of thought and perception. That's the sweep of the frontal lobes, the linear logical reasoning system of the frontal lobes. And it's a skill set. You have to learn how to do a mental status exam of thought and perception. So the diagnosis of a thought disorder is not based on a history. It is an affirmative diagnosis. We are seeing the delusional thought disorder in our session based on the mental status exam. That the delusion is elicited during the clinical interview session through the mental status exam of thought and perception. So here's from Martin a description of the mental status exam of thought and perception. The inability to process information correctly is part of the definition of psychotic thinking. How the patient perceives and responds to stimuli is therefore a critical psychiatric assessment. Here we go. Does the patient harbor realistic concerns, or are these concerns elevated to the level of an irrational fear? Is the patient responding in an exaggerated fashion to actual events, or is there no discernible basis in reality for the patient's beliefs and behavior? So that's what we're going to be looking at with the mental status exam of thought and perception. So here's like the 3 criteria from Martin there. Does the child harbor realistic concerns about the targeted parent, or are these concerns elevated to a level of irrational fear? Okay, if they're realistic concerns that the child's being malevolent, then that's child abuse by the targeted parent. If they're not realistic concerns, then that's a persecutory thought disorder created by the allied parent. Is the child responding in an exaggerated fashion to actual events? And that's typically what happens in the family court situation. There'll be some sort of thing, and then the child reacts and expands it into unrealistic proportions. And is there no discernible basis in reality for the child's beliefs and behavior? So the targeted parent is normal range, and everything's normal range. They do not represent a danger to the child, but the child believes they do. There's no discernible basis in reality for the child's fears that they're being malevolently treated in some way. So here's the process of the sweep of the linear logical reasoning system, because I've been trained. Let me say this too. I was trained for 12 years at the UCLA project on schizophrenia in the diagnostic assessment of delusional thought disorders, as well as other symptoms and psychotic symptoms, but also in delusional thought disorders. For 12 years, I was trained annually to diagnostic reliability, 90% reliability to the head of the Brentwood UCLA VA diagnostic unit, Dr. Ventura and Dr. Lukoff, who are also the authors of the brief psychiatric rating scale I'll talk about in a second. So I know how to assess for delusional thought disorder, and that's what I'll be describing here, how to sweep the frontal lobes of the executive function system. So for linear logical reasoning, what you'll see is the person moves from idea to idea, and those ideas are connected by some sort of logical reasoning steps. For what we're looking for is what's called emotional associational thinking. That's the alternative. So it's either linear logical reasoning or it's emotional and associational thinking. And what you'll find with that is the person will start by making these logical connections, but the moment they hit that emotional trigger, they'll pop sideways into this emotional associational thinking. It's not logically connected. It's connected by association to their emotions. And you can, as you're going through step by step, boop, they pop off to the side. So that's what you were looking for in the diagnostic assessment. Is it linear logical, or do we hit that trigger point and it pops sideways? Now, so you start with, what is the evidence for a belief? The belief. So the normal range thinking follows evidence to reach the conclusion, The thought disorder reverses that. It starts with the conclusion that's fixed and then constructs the evidence to match the fixed conclusion. And then there's contradiction or contrary evidence. That's when they say two different things. They say, oh, I want us, the child to have a good relationship with their dad, but their dad is abusing them. Well, that's a contradiction. Why would you want the child to go be with their father if the father's abusing them? You'd want to protect the child if they're abusing, so they're giving a contradiction. So that's one place we can start, is if they give contradictory statements. The other is if there's contrary evidence. So the targeted parent, you say, what is the abuse? And there's no abuse there. And you say, look, there's no physical abuse, there's no sex abuse, there's no psychological abuse. And yet you're saying the child's being malevolently treated in some way. So help me understand that. So you present the contradiction or contrary evidence. And then when you present the contrary evidence, what we're doing is watching how the person processes that information or fails to process it, the discrepant information. Because if you present contrary evidence to them, for example, do the full assessment. You meet with a lied parent, you meet with the targeted parent. You meet with the child, you meet with the targeted parent and the child. Then you meet with the lied parent again. And based on all these other assessments, you're saying there's no abuse by the targeted parent here. That's normal range parenting. So now you present, in that fifth session, you present the allied parent with the contrary evidence of, I'm not seeing any abuse by the targeted parent, and see how they process that information. Normal range parents will be so relieved that there's no child abuse. Oh my God, I'm so happy there's no child abuse by that. A pathological, narcissistic, borderline dark personality will not be relieved, and they will not believe you. They will hold on to this fixed and false belief, maintained despite contrary evidence that the child is being malevolently treated in some way. And you'll see them respond with almost an obsessive fixation at that point. And I'll talk about that later, in things. But they need to adopt the role of a protective parent to deal with their own trauma triggers and stuff. And so they're defining that to be a protective parent, I need an abused child. So that child must be abused so I can be the protective parent to regulate my anxiety. So when you present them that the child's not being abused, they will not accept that, and they become very obsessive about that protective parent role. But you won't see that unless you challenge the delusional belief with contrary evidence, and then you will see the delusion just pop out in front of you. So in addition, as you're doing the mental status exam, this is for identifying the thought disorder. So what you want to do is, when the person triggers on that associational thinking and you get that emotional association over to this new line of thinking, associational emotional thinking, you want to stop that from happening. And you want to contain them within a linear logical line. And that's going to put pressures on their psychological defenses. Because when they hit that emotional triggering point, their anxiety goes up a lot. And so that's where it pops it out into the associational thinking of, oh, the child's being abused and everything's happening based on this trigger within them. And so if you contain that and don't let them vent it into this delusional belief system, that's going to contain that anxiety within them. And that's going to start collapsing their defenses. And so when they do that, you pop them back in and say, wait, that's not in line here. You're not. And so you get them back on linear track, and they try to pop off again, and you keep them on a linear track. And so this is, attorneys in the family courts can do this on cross-examination. Okay. And at some point I'll teach the attorneys in the family courts how to pop a delusion out on your cross-examination, because your lines of questions are so linear. And you can get the court reporter to read back what they said before, and you're non-responsive to the question. Listen to the question. This is a question, and you keep them on a linear track. You will keep that anxiety contained, and that will collapse their defenses, and boop, out pops the delusion. right in your session or in your cross-examination. And so preventing the emotional escape into associational thinking will collapse the person's defenses. And what you will then get out of the person is flight or anger. So if you're holding them on a linear line and that anxiety is getting too much, they will either attack you and say, I never said that, and you're putting words in my mouth, and they will get very aggressive about staying on a linear logical line and things. Or they will just get up and walk away. They will just leave because the anxiety is too high for them. And if you don't let them defend against it by this associational thinking going into their thought disorder delusions, then they will have to escape the situation. So they either escape it by pushing you away or by actually walking away. And if though they remain in that situation and you keep them contained within a linear logical line and don't let them escape, the next you'll collapse them down beneath the contradictions and the thought disorder, and you'll collapse them into a mild dissociative state. And the mild dissociative state, because they just can't handle the anxiety, they have to kind of zone out on it. This is trauma disorder. So you get that mild dissociative, and that will show up when they start to say, what? You ask them a question, they go, what? And what? They cease to comprehend the nature of the question. So sometimes you break it down into nice little pieces if you want of the question and give it to them in small pieces, and then watch, they won't be able to process even the small pieces. They'll also say, I'm confused. I'm confused. Wait, what? I'm confused. Those are symptoms of a mild dissociative state because you're keeping the anxiety inside and they have to get away from it. So if they can't get away in the delusion, or if they don't get away by escaping or by getting you to back off, they will mentally escape from it by becoming confused. And what? I'm confused. And occasionally they'll just zone out. I've seen that on a couple of occasions where you collapse it into the situation and you'll see the person's eyes just sort of blank over. And they won't say anything. They won't respond. They just kind of go blank. And then you ask them the next question and boom, they're right back again. Now, typically for a mental status exam, when I'm conducting one for a delusion, I won't collapse the person into dissociative state. I get the delusion, I see it, I pop it out, I get it, and then I've seen what I need to see. But if you want to collapse it down all the way to the dissociative state, you can do that. Just keep them on a linear logical line. Don't let them associate out into their defense of their persecutory delusion. Now, once the delusion has been identified and confirmed, then allowing the associational thinking will display the delusion and its features. So once it pops out and you've got it, by allowing the associational thinking, you'll provide an opportunity to assess the nature, scope, and the features of the persecutory thought disorder. So when I'm conducting a mental status exam for a delusional belief, I'll take it in, I'll get down, and I'll do typically 2 or 3 times. I'll pop it out and see the associational thinking over delusions, hold it back in, and get a little defense. Okay, so I've got it now. I see that. Now I will allow them to move into their delusion. So I'll ask them again. They'll just pop in and associate out, and I'll let them do that. And then I will ask them about their concerns and their fears. And as they're giving me that, they're giving me the delusional characteristics. And so I can see just what they believe, how severe is it, how crazy is it, what's the extent and nature of their delusion. And so first identify it, then draw it out right in the session. So it's not based on history. I'm actually looking at the delusion in the session, which is why we can rate the quality of the delusion using something like the brief psychiatric rating scale. And now here's the final statement from Martin regarding the mental status exam of thought and perception. Now, there's different mental status exams. There's one for language, there's one for memory, there's, spell the word world backwards. That's one of the questions on the mental status exam for memory. There's mental status for attention, for emotions, for various things. This one is for thinking and perception. So this is a frontal lobe logical reasoning system. Of all portions of the mental status exam, the evaluation of a potential thought disorder is one of the most difficult and requires considerable experience. The primary care physician will frequently desire formal psychiatric consultation in patients exhibiting such disorders. I agree. That's why I had 12 years of training. We would watch 10 videotapes that Dr. Ventura had filmed the previous year, and we'd have to match his ratings on all the symptoms as a gold standard for that to a 90% reliability. So yeah, it's difficult. I just explained how to do that. But if you don't know, if you're not experienced with popping a delusion out in your session and seeing the associational thinking and seeing what's going on with that, then you don't know quite how to conduct one. Okay, and you're kind of flailing about a little bit, which is a little uncomfortable, flailing about in somebody's psychology if you don't know what you're doing. So it requires considerable experience, and oftentimes for most mental health people, if you're dealing with a thought disorder, you want to get it out to somebody who can assess for a thought disorder. Typically that's psychiatrists. Typically they work in schizophrenia and delusion. You won't find anybody in the family courts who can do this because that's not what they do. They're working with, whatever they're working with. The incompetence in the family courts is pretty severe. So you won't find this in the family courts. So what I recommend, people, I am competent. I recommend that the mental health people who are doing these assessments get a hold of me and consult on how to do this, how to do the interview, and how to assess for a thought disorder. Or that my typical recommendation is that the court appoints somebody to do the assessment and let each parent litigant appoint a second opinion consultant on that. And so if the targeted parent then appoints me as their second opinion consultant through telehealth, I'll be sitting in the session and I can do the mental status exam in coordination with the therapist who's actually in the room. We can talk about it ahead of time. We can do it, and we can pop the delusion out if it's present. Or if it's child abuse by the targeted parent, I've worked foster care. I know child abuse. I can do, assess for child abuse by the targeted parent if that's what's happening. But if it's not, then let's get an assessment. So that's what I typically recommend, that the court appoint somebody to conduct the assessment and that each parent litigant appoint their own consultant. So we might wind up with a 3-doctor panel. That's like a 3-judge appellate panel. I guarantee if you get 3 doctors on this, 2 in telehealth and 1 in the room, the court's going to get a good report. And then the court can look at all that and make its decisions about child custody and what to do off of that. So that's typically my recommendation for things. But look at me, I'm an old guy. I'm not going to be here forever. So we have to build capacity out there. So yeah, it's one of the most difficult. Yes, that's true. Requires considerable experience. Yes, that's true. And they will typically require or seek consultation. Yes, that's true. And so we need to alter how we're responding to the pathology in the family courts. Now, this is from the National Academy of Sciences, Engineering, and Medicine in a paper they developed and wrote called Improving Diagnosis in Healthcare. And it's about second opinion consultation, because that's what we do in healthcare. That's what doctors do to improve our diagnosis, to return an accurate diagnosis, because we need an accurate diagnosis for our treatment plan. We consult. You go into the doctor and say, "Doctor, this hurts." And the doctor says, "Let's get you an orthopedic consult." Boom, right away. And that's what we do throughout healthcare. That's what we need to do here. Any diagnosis returned into the legal system is going to be a disputed diagnosis. And the appellate system for a disputed diagnosis is second opinion. So we know it's going to, so let's get a second opinion through telehealth. So here's what the National Academy of Sciences says. Clinicians may refer to or consult with other clinicians, formally or informally, to seek additional expertise about a patient's health problem. The consult may help to confirm or reject the working diagnosis, or may provide information on potential treatment options. Clinicians can also recommend that the patient seek a second opinion from another clinician to verify their impressions of an uncertain diagnosis, or if they believe this would be helpful to the patient. So the threshold is really low. If you believe it would be helpful to the patient to get a second opinion, refer to a second opinion, recommend a second opinion. We should be having second opinions on all these diagnoses because they're going to be a disputed diagnosis and we need an accurate diagnosis. So let's get in the proper mental health expertise to make sure we get an accurate diagnosis for the court's consideration. Here's APA Ethics Code Standard 3.09, cooperation with other professionals. When indicated and professionally appropriate, psychologists cooperate with other professionals in order to serve their clients and patients effectively and appropriately. So ethically, we should be consulting. Practice standards, we should be consulting. This is possible child abuse. This is a difficult exam. We need to get it right and accurate. If we misdiagnose child abuse, it's going to devastate the child's life. Let's do what we need to do. Let's get the consultation necessary to return an accurate diagnosis for the court to rely on in its decision making. Court has tremendous decisions about this child. It needs an accurate diagnostic information about which parent is abusing the child. Now, here's a brief psychiatric rating scale. This is what I was trained in. It's one of the oldest, most widely used scales for measure psychotic symptoms. So here's from the BPRS, Wikipedia. The Brief Psychiatric Rating Scale, BPRS, is a rating scale which a clinician or researcher may use to measure psychiatric symptoms such as depression, anxiety, hallucinations, and unusual behavior. The scale is one of the oldest, most widely used scales to measure psychotic symptoms. Was first published in 1962. An expanded version of the test was created in 1993 by Dr. Lukoff, Keith Nectarline, and Joseph Ventura. Now, I was working at Keith Nectarline's lab at UCLA on schizophrenia, and I am trained to diagnostic reliability at 90% to Dr. Ventura and Dr. Lukoff for 12 years. Okay, so I know how to assess for delusional thought disorders. So he's starting with one of the primary issues is full conviction, because that's going to differentiate between a rating of 3 or lower, which is not pathological, or 4 or higher, which is on a 7-point scale. So here's the definition of full conviction. Consider the patient to have full conviction if he or she has acted as though the delusional belief were true. Ideas of reference persecution can be differentiated from delusions in that the ideas are expressed with much doubt and contain more elements of reality. So on a rating of a 2 or a 3, subpathological, you might have ideas of persecution, but they're going to be held with some doubt and less certainty. But if you have full conviction that this delusion is true, the person has acted as if the delusion was true, boom, you're up to a rating of 4. At that point, you have a thought disorder and with full conviction. Now, the rating of 2 is ideas of reference. People may stare or laugh at him. That's a different type of delusion. Or ideas of persecution. People may mistreat him. Unusual beliefs in psychic powers, spirits, UFOs, or unrealistic beliefs in one's own abilities. Not strongly held, some doubt. So here we would have ideas of persecutory beliefs, but they're not strongly held, and there's some doubt to it, is what we're looking there. Now for 3, it's the same as 2, but the degree of reality distortion is more severe, as indicated by highly unusual ideas or greater conviction. So the ideas here are not going to be unusual, but they're going to, so what we're looking here is the greater conviction. Content may be typical of delusions, even bizarre, but without full conviction. The delusion does not seem to have fully formed, but is considered as one possible explanation for the unusual experience. Now, for 4, we get delusion present, but no preoccupation or functional impairment. So now we have full conviction. The child has acted upon the belief that they are being malevolently treated some way. The allied parent has acted on the belief that the child is being malevolently treated when they're not. And so we have the delusion, but there's no preoccupation or functional impairment. And it may be an encapsulated delusion or a firmly endorsed absurd belief about delusional circumstances. However, in the family courts, we do have functional impairment in the family relationships. It's destroying the child's attachment bond to a parent. And we typically have a fair degree of preoccupation in the child and in the allied parent. So it elevates it up off of a 4 to a rating of 5, a moderately severe persecutory delusion. That's what we have in the family courts when we apply the criteria of the brief psychiatric rating scale to our assessment. Full delusion present with some preoccupation or some areas of functioning disrupted by the delusional thinking. That's what we have. And so I want everybody to understand this. If we apply the DSM-5 and we apply the criteria of delusional thought disorder diagnosis and we apply the BPRS to rating it, we have a moderately severe, at least a moderately severe persecutory delusion in the child and in the allied parent, and it's not being diagnosed and it's not being treated. And that's child psychological abuse. It's not being diagnosed, not being treated. It is really bad in the family courts. We need to get a proper risk assessment for this stuff. Now, for a rating of 6, is full delusion present with much preoccupation or many areas of functioning are disrupted by the delusional thinking. And a 7 would be even more functional impairment, even more areas of preoccupation on this. So that's what we're looking at here. We have in the family courts at least a moderately severe rating of 5, and then we would look at the degree of functional impairment. Are they getting admitted to psych hospitals? That's going to be a 7. If that's just, again, admitted, if the police are being called, that'll be a 7. If the child is obsessing about, I don't want to be with the parent, is getting really anxious, that's going to be a 6 or a 7 because of the preoccupation quality of things. It's at least a 5 because there is functional impairment and there is full conviction to the false belief. So, the family court pathology. The child and parent share a fixed and false belief that the child is being malevolently treated in some way by the normal range parenting of the targeted parent. The child has acted on this belief. There's a full conviction, a BPRS rating of at least a 4, an encapsulated persecutory delusion, and there is significant functional impairment in the family relationships and preoccupation, which is a BPRS rating of at least a 5, moderately severe. Creating a child psychological abuse, creating a shared persecutory delusion in the child that then destroys the child's attachment bond to the other parent is a DSM-5 diagnosis of V995.51 child psychological abuse. Disputed diagnosis, second and third opinion. I spoke about this a few seconds ago. Any diagnosis returned in the legal system will be a disputed diagnosis. The appellate system for a disputed diagnosis in healthcare is second or even third opinion. In all cases of court-involved custody conflict, a second opinion or even third opinion on the diagnosis should be routinely obtained through telehealth consultation at the time of the initial assessment. So here's my diagram for that. The court should designate a primary psychologist to conduct the diagnostic assessment and should allow each litigant parent to appoint a second opinion consultant through telehealth for the assessment. That will do the diagnostic assessment, then the court can make its decisions and we can move on to a treatment plan. Another way to view this diagram is if you flip it on its side, because it extends out into treatment, that these consultants to the initial diagnostic assessment can then also serve as consultation resources for the mental health treatment providers to ensure successful treatment. So not only have you improved the diagnosis, you've improved the quality of the treatment by getting consultants into the process to assist the family therapist with the treatment of the delusional thought disorder and the child psychological abuse. So that's the assessment for a delusional thought disorder, and that's how I recommend we address that issue. In future seminars, I'll talk about the assessment for the factitious disorder and for other aspects of the family pathology. So with that, take care, everybody, and good luck out there.